Hi everyone. Thanks for showing up to the in-service and being interested in my research. My research is the effects of ankle sprains and single versus dual task paradigms on coincidence anticipation performance in female high school basketball players. It's a long title, so hopefully within these few slides, I'll be able to explain what I'm researching and everything about this concept. As you can see below is a lot of collaboration that I needed to complete this project, and I want to thank Dr. Kovacs from UWL. He did a lot of work with me on planning out data collection and going over motor program concepts. Dr. Emily Wogalter, she's my mentor from San Jose State University. We looked at ideas of this maybe I think about 5 or 6 years ago in undergrad. However, I was never able to even get the IRB done, and this time I was able to relate it to more of a rehab perspective than training. Nate Venata is a faculty mentor at Gundersen Sports Residency. He's been awesome. Plenty of moments where in he's in the office, and second he takes his heads off or his headphone off, me and Danny kind of started asking him a lot of questions about research. So he's been helpful. And then last but not least, Dr. Thomas Kronozik. He's in charge of the LIMS lab. A lot of really good research out of there. He's looking at a lot of multitasking, dual task studies as well, and he helped quite a bit with the final poster being concise and clear with my explanations, and also the statistical analysis, and just reviewing over it all. So again, thank you, and I just want to really give them credit for helping me, and that I need a lot of help with research, and this was definitely my weak point, and I'm grateful for all their guidance. So thank you at Gundersen. This is about 11 months in, 1 month left. It's been an amazing year. I think a lot of people are nervous about residency, but it was definitely the right choice. You know, a California kid moving to Wisconsin to learn and get better. I definitely think I've gotten better academically, clinically, and just as a person from being around everyone. So thanks everyone. So obviously we're going to go over my research in this, but to understand my research, I do have to explain a few things, and hopefully you guys learn these objectives from this in-service today. So objective number one is to learn about coincidence anticipation time. I'm going to be shortening it as CAT or CAT, and its relationship to motor programs. Next is to learn the difference in CAT between single task and dual task. So learning about uh, how it affects if you're doing one task versus multiple tasks at once, and then learn what components of motor programs are altered after injury. Coincidence anticipation time is the ability to predict when an object will arrive at a designated point in space at a specific time. So imagine some baseball player hitting a ball. He has to predict when that ball is going to hit a certain location at a certain time. That's how well he can time that is going to be his coincidence anticipation time performance. Another example on screen is, let's see this arrow right here on the screen. I have to predict when, if I were to drop a ball on the screen right now, which I will, I have to predict when it's going to go there. So I'm going to drop a ball on the screen, and I'm going to say here when I think it's going to stop right there. Here. So I said it too soon, so it means maybe my coincidence anticipation time would be deemed poor. Well, it depends on what we look at, but as far as what it is, that's how I would best explain it. The Basson timer is an instrument that's commonly used. It's currently the gold standard right now. It's this machine right here pictured. So in this a light starts at one end of the bar. You can set it to different speeds and variables, and light will move down the bar at whatever variables you set. And then at the end of it, you have a object you can manipulate. Sometimes people can swing a bat through a sensor. Some people can step on a plate. For us, we just had a simple button push. So when the light hits the last light that we designate, a person has to push the button when they think that light will reach that point. And in turn, the device gives us some raw data. It gives us some time, which we can calculate absolute error and constant error. Absolute error is the magnitude of error regardless of early or late response bias. So let's look at this line right here. So if they get a 0, the closer to 0 they get, the better. that's going to be a correct response because they guessed exactly when that light would land on that designated point. But let's say, like me in that example, I said, or I pushed the button too soon. So I pushed it at negative 80 milliseconds. That means there was an early response bias. However, absolute error only looks at the magnitude of error. So in this case, the absolute error is 80 milliseconds. It doesn't care whether someone was early or late. For constant error, that's the magnitude of error with indication of performer's response bias. So taking the same example, again, we want 0, but I responded to early. So that would give me a constant error of negative 80 milliseconds. So again, it appears to be the same, but based on which error we look at, it's a different value. And I chose these two errors because absolute error, what that does is, I think just it's worth looking at if we're going to eventually compare injury, because if you can imagine, someone initiates their motor program or movement too early or too late, that could cause possible injury or lead to possible injury. For constant error, I chose that because I would think people want to respond earlier, because if you're too late, you didn't guard or stiffen up when needed to at all. So we didn't study relationship or risk of injury with this study, but that's why I wanted to look at these errors in general, and I wanted to see if dual tasking and presence of an injury would have an effect on these errors. And so these were the measurements I wanted to look at. So you could see here how it could be important in sports for performance and for maybe a head injury. So this is a softball player. Imagine if she mistimed it or didn't have her glove in the right location at the right time. That could lead to that either a head injury or just a base hit. Another example is it could actually help performance. Well, what if you could avoid shots like this, like Muhammad Ali? Maybe combat sports could benefit from stuff like this. So to understand what part of the motor programming the coincidence anticipation time relates to, we'll look at a simple reaction time task. And then we'll also explain how the Basson timer isolates this. So with a simple reaction time task, you have a stimulus that comes into play. That stimulus, whether you know it's existing or moving or not, it's in play. At some point, you're going to identify the stimulus. So let's just say a basketball in this example. So the basketball gets shot up, and then you identify the basketball. The basketball is important to you. You want to look for that basketball. Once you see that basketball, you need to decide what to do with the basketball. So in this example, let's say you're going up for a rebound. If you're close to the ball, you're in the key, you're probably going to want to go for the basketball and box out. So your response selection is box out, jump up, grab the ball. Another response would be to, if you say you're at the near the 3-point line, you're going to just box them out, make sure the ball, make sure no one comes in and grabs the ball. At that point, you determine your motor program. So now that you selected whether you're going to box out or box out and rebound, you're going to decide in your head what motor program you're going to use for that. And the motor program can be broken down into two different features. So the first is invariant features. These features don't change. And as I explained them, it'll seem like they change, but they actually don't. So if you've practiced a motor program and movement over time, over and over and over, you actually kind of develop this, I'd say, conceptually rigid pattern. So relative sequence is the sequence at what your limbs move. So let's go back to the rebound example. Say you're about to jump up for the rebound, so your legs are going to move before your arms, before you grip in that sequence. Next is relative timing. So relative timing is at what point does your arm move after your legs move. And then relative force is your legs are going to produce more than your arms, and your grip is going to produce a little less than your arms. And as much as that may vary, they're actually relatively the same. And so when we talk about it, variant features, absolute force is going to change. So these are all things that change. Absolute force is going to change. Absolute time is going to change. So absolute force is just exactly how much force you have to produce just to grab the ball. So say the ball is really, really high, you have to produce overall a great amount of absolute force. And then absolute time is you have to think about how much time it's going to take to get there. It may be shortened or increase as the ball is higher or lower. And then effector is kind of the best way I can explain it is kind of like some constraints. So say your constraint is that the ball is coming on the left side, so you have to use your left arm. It's going to be the same motor program, but it's going to look or be slightly different just because it's your left arm and it's your non-dominant. You're not familiar or as accurate with that arm. So looking at these invariant features, they don't change. Even though the absolute force is going to differ, your relative sequence of limbs moving is going to be the same. The timing is relatively going to be the same, and then relative force of what limb or joints produce more force is going to be the same. Same with absolute timing. So that may change how long it's going to take you to get somewhere. You need to be somewhere, or how short you need to be somewhere. But as far as the invariant features, all those relatively stay the same. So how does the Basson timer relate to this? So with the Basson timer, we look at just one variable of this, and we'll explain why. So with a Basson timer, like I said, it's a light going down the track, and then you push a button with your thumb to best predict when that light is going to get to that point. So the stimulus is going to be the red dot. So stimulus and stimulus identification are already out of there. You don't really need much of that. You don't need to do that with this task because you already know it's a red light, so you already identified it. Response selection, this one doesn't. The Basson timer takes this part, the simple reaction time task, out of it too, because you only have one response, and that's to push the button. There's no choice or task where we say, hey, if it's this color, you can just skip it, only do this color. It was simply push the button when you think the red light's going to get there. As far as the motor program goes, relative sequence is eliminated because you only have one joint moving, that's going to be the thumb. And again, that takes away relative timing and relative force because you really only have one little joint moving. Absolute force is taken out. It's a novel task, so the amount of force you have to determine to push in that button is very little. And then the effector, we actually had everyone use their dominant arm to do this to make sure they're familiar with it. So again, the Basson timer actually looks at absolute time. It's your ability to look at the total amount of time that you need to have in order to be in the right place at the right time or manipulate an object at the right time in the right area. So quite frankly, with the snap of a finger, all those disappear, and you only get absolute time when you look at the Basson timer task that we had chosen. So now that you understand the Basson timer and coincidence anticipation time, hopefully, let's go on to talk about why I want to do this research and why it's worth looking at. So why do non-contact injuries happen? Is it poor movement? Definitely. I mean, it could be poor movement. Well, we don't know for sure as literature is changing. It seems to be shifting as with most research. Prevention programs like the Sports Metric program, they actually reduce injury rates and lower extremity injuries. However, they also change your biomechanics. On the flip side, the FIFA 11 Plus is probably the most popularly studied injury prevention programs that have been shown to decrease lower extremity injuries overall. However, Amy Arundel and her colleagues looked at biomechanic changes over 2 seasons, and they found no changes, but they did find reduced injury rates in Division I players, soccer players. What about poor rehab and testing? That's absolutely true. So Toole and his colleagues in 2017 found that only 14% of athletes passed tests before clearance. So a lot of PTs aren't rehabbing correctly or just aren't testing correctly. How about them returning too soon? So we're from the Midwest, and a lot of people looking at ACO research know the name Tim Hewitt. He's talked about a 2-year model of return to sport just because you can be as strong as you want, you can be great at everything, but tissue healing just takes time for that ligament to, or that tendon graft to ligamentize inside that joint again. What about poor adherence to clinical evidence and guidelines? So we have clinical practice guidelines now. We have a really good injury prevention protocols that are being shown to be effective. 20% of PTs do not do any strength testing before clearing. So Greenberg surveyed nearly or even over, I think, 2,000 PTs that are in the ortho and sports section, and he found that 20% do not do any strength testing before clearing. And of the 80% that do the testing, a lot of them still use manual muscle tests, which is a test of weakness rather than strength. So maybe we're just not adhering to the clinical evidence that we need to do for return to sport testing. In addition to that, there's low compliance with effective prevention programs. I mean, a lot of times we approach coaches, what if we told you that we can prevent lower extremity injuries overall from you? And there's just low compliance with that for reasons we still haven't figured out. Yet when we look at compliance rates and injury rates, they happen to correlate. What if I told you about neuroplastic changes too? Well, that's actually an area that's actually being studied by Dustin Grooms and a lot of his mentors and mentees in Ohio and Ohio State University. They're doing a lot of good things, and it's just a new concept that we're kind of looking at and can be an area to study and discuss, especially in my experience. This is where I kind of got this idea. And I know it's a crazy idea, but it's definitely worth it to look at. So in the past few years, there's been a few studies that came out. I'd say these are the big ones in the rehab world. Again, you'll see Dustin Groom's name on a lot of it, James Onnit, Gregory Applebaum. Those are a lot of good names overall to look at it. Ajit Chowdhury, really good people putting out research, really doing the hard work of looking at neuroplasticity and measuring all of that. I'd say the big landmark study, I'd say in PT in the past years, or a few years, would be the top left corner, neuroplasticity associated with anterior cruciate ligament reconstruction. So in this experiment, what he did was he did a functional MRI of people's brains as they were performing a Chardarc quad. So this is his ACL group. Most of them had hamstring graft. They were all university age. It was all in their left knee. The interesting thing was they varied from 6 months to 5 years post-op. All of them said they had intense rehab. They talked about doing plyometrics. However, there wasn't a standard program as what's kind of familiar with clinical practice. There's a little, if not too much, variability. In addition to that, they were cleared by a physician for return to sport. They chose the Chardarc quad because it's it would reduce the amount of artifact on the imaging because it's less movement. It's a small movement, and a Chardarc quad is an exercise that best isolates the quadricep muscles. The control group was pretty impressive. He matched by age, sex, height, mass, leg, arm and dominance, education level, physical activity level, and sports participation, both in years and experience. And they had no history of injury. When they did the IKDC as a functional outcome measure, there was no difference. So both of them all self-reported that they felt pretty darn good. What he found was pretty interesting. So the blue is areas of lower activity, and then the areas of orange is higher activity. And I really don't like making a narrative. I think everyone's interpretation of research is interesting, but I don't like to push a narrative. However, I will say a lot of his findings are consistent with what we see clinically. So for the cerebellum, if that's decreased, that controls motor control of posture. So that could be why people lack balance. And again, this wasn't a balanced task that he did the image on. It was a simple Chardarc quad, yet that showed lower development in those with ACL reconstructed knee. As far as the ipsilateral motor cortex area, that was also inhibited, and that inhibits motor drive of the contralateral limb. So if that area is inhibited, you may want to rely more on the other side, which may mean maybe that other side isn't strong enough for the amount of use you want to use it for, and also that may be why people kind of shift away even 5 years out of their surgical leg when we look at how equal they weight bear. And for the orange, again, this is increased area, so the contralateral motor cortex. This inhibits motor drive of the ipsilateral leg. This may be why we have a hard time getting that quad deficit back, and people just have a really hard time activating that surgical leg of the quad. Lingual gyrus, so because after reconstruction you do lose the proprioceptive parts of the ligament, you're going to rely more on your vision system for balance than the proprioception in the knee. And then lastly, bilateral pain and sensory is also areas of the brain are heightened, and that could explain why people have some pain in the knee and develop chronic pain. So I do want to say, yes, it could be the graft harvesting that could keep people's knee achy. It could be them just building up some scar tissue and laying it down and really not getting good rehab after and just getting a stiff knee, and that leads to increased patellofemoral joints. But this could also explain those rare patients we have where we just really don't have an explanation for how much pain they have, even again 5 years out. And this is what he looked at. It was 6 months to 5 years out, and this seems to be a consistent finding. Well, how about for the ankle? So a really good systematic review looking at the effect of cognitive loading. So kind of doing tasks while you have to think and make decisions on motor behavior in injured individuals. And Chris Burkall and colleagues, they looked at this for ACL reconstructions, ankle instability, chronic ankle instability, and also low back pain. The brain, what they found overall is that the brain has limited resources and it has to allocate its activities correctly. So they found a lot of differing and variable results. And one takeaway they brought up was that the hard part about studying this is they have to think about the correct challenge of cognitive load and the physical tasks. So some tasks would be cognitively challenging, while for that one individual, the physical task wasn't. On the other end, you had individuals who were physically challenged, but the cognitive task wasn't as well. So that's going to be a hard part in future research as well. But the main thing they said was if you're physically challenged, more resources are going to go to that motor component of your brain rather than the decision task, and vice versa. Another really good study is the central nervous system adaptation after ligamentous injuries by Neal et al. That one is pretty good in the sense that they looked at all different types of ways to measure brain activity and looked at ACL reconstruction and ankle ligament injuries. So they talked about all the different methods of measurement and what it means clinically that we see so far. One thing they wanted to point out was there was more demand on somatosensory cortex when looking at the EEGs of those with chronic ankle instability and sprains. So that they found that there was poor ability to discriminate load at initial contact. So right when someone landed, it was hard for them to discriminate how much force they had to produce with their muscles in order to resist that. And this is a picture of an EEG. So you have those wavelengths that can show what areas are heightened. They also found that with greater laxity of an ankle sprain, there was greater inhibition from the fibularis muscles. And the authors did mention at the time there's an unpublished thesis showing data similar findings with the functional fMRIs that Dustin Groom showed with this ACLs, but this one they found was for ankle injuries. And they also commented that the descending pathways are altered. So in the past, it was all about mechanical reasons why people couldn't produce force and activate their muscles. And could it be inhibition and pain? Well, definitely possibilities there. This just kind of gives it a different perspective to look at why this is inhibited. We don't really know if it's the chicken or the egg, whether it was the brain or those mechanical symptoms inside the surgical leg that are causing these inhibitions of muscle activity. So now you guys can understand how it relates to sports and injury. So let's imagine this girl, she jumps up and grabs a basketball. She's looking at her surroundings. She has to predict when she's going to land on the floor, and that's going to help her contract her lateral ankle muscles as best as possible to resist a sprain and have a good landing. And so hopefully that brings it into why this is being studied and how it can coincidence anticipation time can relate to ligamentous injuries. So the purpose of my research is to determine the difference in coincidence anticipation performance across single versus dual task performance. So I just wanted to see if there was a difference, whether it's direct or not, whether people's ability to determine absolute time is changed at all. The next was determine if there was a difference in a dual task performance between injured and uninjured players. So in essence, I wanted to see the effect an injury had on a person's ability to determine on a person's coincidence anticipation performance. So my methods, there were 21 high school females, 16 years was the average age. They were each going to do a single task and a dual task. So the single task was the Batson timer task where they just push a button, predict at 3 different speeds. So the speeds I chose were 9, 12, and 15. The next task was a dual task. So anticipation timing was done on the Batson timer again. However, this time they also used a dribble a basketball at 90 beats per minute. In order to make sure there wasn't a learning effect, I did modify the design a little bit instead of everyone just going down. So they were randomly assigned by a convenience method. So 11 of them started with a single task first, and then 10 of them started with a dual task first. This way I just want to make sure that they weren't warming up with a single task, and then all of them would actually have better dual task if that was a phenomenon that we observed. With a warm-up, they just did 3 trials, so 1 at each. Again, just to avoid a learning effect, they practiced at different speeds and they were actually tested at. And then the order 1, so they did a single task and then the dual task, whereas order 2, they did the dual task and then the single task. We took the data from Batson timers, and then we got the constant error and absolute error. And we did look at injured versus uninjured, and although they were randomly assigned, we actually really lucked out. The people that we studied, there was actually a fairly even amount who were injured and non-injured. So we had 11 who were not injured, and we had 10 who actually had a history of an ankle sprain. We did an ANOVA to look at single versus dual task, absolute error, and constant error. And we did a multivariate analysis to look at dual task, absolute error, and constant error for those who have been injured and those who have not. So we didn't look at the single task, we looked at the dual task because we wanted to see how they did under a cognitive load. And then we calculated effect size and looked at that too, and our significance was set to 0.05. So here are the results between the absolute error and single dual task. So again, the absolute error is just the magnitude alone. It doesn't talk about whether they were early or late. And overall, the dual task at each speed, they actually had a bigger error compared to the single task. However, it wasn't significant. It wasn't statistically significant, but there was a trend of it. And the differences between single and dual task, that varied from about 11 milliseconds even to 6 milliseconds. So 6 to 11 milliseconds was the amount of difference, the range of difference at each speed. Next was constant error. So this looked at how the response was, and as you can see on the graph, you'll notice in the blue that's the dual constant error. So people who were doing the dual task, when they did the dual task, they had less of an early response bias. So they were, we could even say, delayed compared to the single constant error. But again, there was no significance, statistical significance in this as well. And the average was about 4 to 9 milliseconds when looking at all different speeds. And then let's look at the injured versus uninjured group. So those who had an history of ankle injury, one thing we found was that except for 9 miles an hour, there was a bigger absolute error in the group that had a history of injury, although it wasn't much. And again, there was no statistical significance. And then for the constant error, same thing, the group who did have an injury, they trended more late, so they had less of an early response bias in this group, and quite a lot for 9 miles an hour, actually quite a lot for all groups in general, but again, not statistically significant. One thing that was not in our purpose that we did observe was the effect of speed. So we found that, as you can see in our past graph, speed had a significant effect um, on all of the measurements we looked at. And in past studies, they actually found that as the faster you go, the bigger absolute error you have. So the greater error you're going to make, the faster you go. Well, we actually found the opposite in ours. So we found that the faster you go, the actual less of an error you have. And I think you can argue both ways. So I think if you had, again, if it's fast, then people may just not do well with fast objects. However, in our study, we thought that if you have a faster stimulus, you would have less time. And less time, that means there's less noise to intake, and therefore you may be more accurate in your coincidence anticipation performance. So we didn't look at it, but just an interesting observation compared to other studies. So discussion, the addition of multiple tasks increased absolute error and produced less of an early response bias. However, it was not statistically significant. Increased absolute error and less of an early response was found in an injured group when compared to uninjured. However, results were not statistically significant. One interesting thing I thought is, although not statistically significant, is it clinically meaningful? So there's been studies out there that show ACL injuries, the actual injury occurs within 17 to 50 milliseconds. So even though it wasn't statistically significant, we did find some errors ranging from difference in errors ranging from 4 to 15 milliseconds. So although it wasn't statistically significant in our study, when you think about that 17 to 15 millisecond injury time, it may be important clinically in that way. We also found that as speed increases, overall absolute error decreases, and take it for however you want. Maybe we didn't have a hard enough cognitive task, or maybe we didn't have a hard enough physical task. Just a lot of things to think about when we saw that. Limitations, we had relatively slow speed. So when I looked at the research, they said the past research of doing 8 miles an hour was plenty fast enough, but I didn't find any good explanation on why and how they determined that was fast enough. So I chose to go faster at 9, 12, and 15. Although mine was faster than theirs, we have objects that go pretty fast in sports, up to 80 miles an hour in sports such as soccer, tennis, and football. We had a small sample size. That's the biggest critique. We did a power analysis, and we were hoping to get 68, but due to timing constraints and schedules, we were only able to get 21 people. I do have some soccer players. We may not use that data just because there were some confounding factors, such as when I did theirs, they were fatigued since I was pulling them out of practice, whereas the basketball girls, I took them right before or after practice when they had plenty of rest. And then also the soccer girls were outside versus the basketball girls being indoors in a quiet office testing space. Also, the basking timer is apparent motion. It's not true motion. So apparent motion is the dots are moving to appear like there's movement. However, real movement is an easy flow with acceleration, and we could have set acceleration on the basking timer, but that would take a lot more math and calculations to figure what's accurate in basketball or soccer. And then task selection, like I said, maybe we didn't choose the correct or challenging enough cognitive task or physical task. So conclusion, additional tasks added during performance and rehab training may not affect or challenge an athlete's coincidence anticipation significantly different than performing a single task. So because there was no statistical difference, I just wonder if our multitask training will lead to improvements overall during sports settings where they have a cognitive load and are distracted. Future studies with larger sample size and faster speed may reveal significant difference and effects. We did have some moderate effect sizes. I don't know how results will change, but maybe we will see interesting findings with a bigger group. So what's next? I'm still continuous with Dr. Kovacs. We're looking at any other analysis we want to do on it, and also we want to include the soccer players. He has this algorithm where, because Bath and timer research and coincidence anticipation data, they often have a lot of outliers. He has really good algorithm to look at what data we can use from the soccer players. Soccer findings. So what if soccer players are really bad? So I'd say the range between coincidence anticipation time for basketball players was between negative 300 and 300. Interesting for soccer players, it was up to negative 1,000 to 1,000 milliseconds, which is interesting because we had a lot of dual sport athletes, so basketball and soccer. Just for the sake of time, I didn't redo the basketball girls, but all the soccer girls that I studied, they had really bad coincidence and patient anticipation performance. It would have been good if I looked at one of the dual sport athletes to see if it was the environment or more of that sport, just because what if soccer players are really bad at it and they happen to have a high incidence of ankle sprains and ACL injuries? So that's just something I considered. Research at higher speeds, higher cognitive loads, higher physical loads. So again, just manipulating the variables. That's going to be something that's very hard in my research and other research in this area going forward. And then knee injuries. I actually wanted to do this on ACL reconstruction just because the work of Dustin Grooms looked at this quite a bit in ACL deficient or reconstructed patients. But luckily, none of the girls had ACL reconstruction injuries. They just had some minor sprains. And then interventional studies. So the point of this research was for me to even see if interventions improving coincidence anticipation time were worth it. One thing I don't like is I don't like treating with fads. And so all the multitask and stroboscopic goggle training out there is cool, and it's been shown. There's early evidence to show it is effective in improving vision skills, attention skills, and coincidence anticipation time. But in the end, if it doesn't reduce injuries or really doesn't change much of things we want to measure, then I think that would change my clinical practice. And what's next? Well, what's still going on? Because there's a lot of people still doing these studies. It's just grown and grown. It was a big hit at CSM, and again, credit to Dustin Grooms, his mentors, and his mentees for introducing me to the work and doing all this. So just interesting stuff, how the brain behaves after an injury. Here are my references, and thank you. I'll be taking questions.